Have you ever had one of those coughs, the kind that just hangs on forever?
Ugh, yes.
Or maybe felt that tightness in your chest, made you wonder if it was, I don't know, more than just a cold?
It happens all the time.
Yeah,
And finding good information can feel, well, overwhelming.
totally. It's so easy to get swamped. But today, we're aiming to cut through some of that noise.
We are.
We're taking a deep dive into the, let's say, complex world of lower respiratory tract diseases.
Yeah.
And we've got some really detailed sources here, including a pretty comprehensive family nurse practitioner's workbook. It lays out the facts on, well, everything from pneumonia to more chronic stuff like asthma and COPD.
And our mission really is to pull out the most crucial bits of knowledge from these sources.
Right.
Help you understand the key differences, how doctors figure things out, the diagnostic clues.
And the treatments.
And the different treatment approaches. We want to connect the dots, give some insight into why certain symptoms matter, how these diseases are managed differently, hopefully make navigating your own health a bit clearer.
Okay, I'm ready. I think there might be some real aha moments coming up. Stuff that might even change how you think about that next cough that just won't quit.
Let's hope so.
Okay, let's unpack this. First up, community-acquired pneumonia. CAP.
Right, CAP.
So let's define that first. Basically, it's an infection in your lungs, right? And the airways leading to them.
Exactly. Lungs and bronchi. And the key is community-acquired, meaning you picked it up out in the world, not in a hospital or, say, a nursing home.
Okay. And often treatable at home.
Often, yes. Treatable as an outpatient, though it can still be serious, of course.
Gotcha. So what are the usual culprits? What causes it?
Well, there's a usual lineup of suspects. Bacteria are common, like Streptococcus pneumonia, that's a big one. Haemophilus influenza, too.
Okay.
Then you've got what are sometimes called atypical bacteria, things like Mycoplasma pneumonia and Chlamydophila pneumonia.
Atypical. What makes them atypical?
Mostly how they present and how they look under a microscope, or rather, how they don't look. They often cause what people call walking pneumonia.
Ah, I've heard of that.
Yeah, it's usually a bit milder, maybe a dry cough, fewer really severe symptoms compared to classic bacterial pneumonia. And a key thing for diagnosis, they don't show up on a standard Gram stain test in the lab.
Interesting. Okay, what else is on the list?
There's Legionella. That one's a bit different in how you get it. And Staphylococcus aureus, or S. aureus, which often pops up after someone's had the flu.
Okay, so Legionella, how does that spread? You said it's different.
It is. You usually get Legionella by inhaling contaminated mist or water droplets. Think contaminated air conditioning systems, cooling towers, even showers sometimes.
Oh, wow.
And here's a really important point. There's no good evidence it spreads person to person.
Okay, so you can't catch it from someone coughing on you.
Right. And certain factors increase the risk of getting really sick from it, Legionnaire's disease. Being older, male, a smoker, or having diabetes are major risk factors.
And those atypical ones, the walking pneumonia bugs, how do they spread?
M. pneumonia and C. pneumonia, mostly through coughing. Close contact. That's why you see outbreaks in places like college dorms, military barracks, maybe even small offices.
Makes sense. And the S. aureus you mentioned, post-flu.
Yeah, that's largely where we see S. aureus pneumonia showing up after someone's already been weakened by influenza.
So it sounds like who gets sick really influences what they might get sick with. Your overall health matters.
Absolutely. It changes the probabilities quite a bit.
How so?
Well, if you're generally healthy, no major chronic illnesses, the most likely causes are things like S. pneumonia, those atypical bacteria we mentioned, M. pneumonia, C. pneumonia, or just common respiratory viruses like influenza, RSV, even COVID-19.
Okay, standard stuff mostly.
Pretty much.
Right.
But if you do have significant comorbidities, things like chronic heart disease, lung disease like COPD, liver or kidney problems, diabetes, alcohol use disorder, cancer, or even having no spleen.
Right, a whole list of conditions.
Yes. Then the list of potential culprits expands. You still have S. pneumonia and the atypicals and viruses, but you also have to more strongly consider H. influenza and Legionella.
Ah, okay. So knowing about those other health issues is critical for the doctor.
It's vital. It helps guide the initial diagnosis and, importantly, the treatment choices.
So speaking of diagnosis, if someone comes in, maybe coughing, feeling unwell, what tests are typically run? What's the minimum?
The essential starting point is usually a complete blood count, a CBC, looking specifically at the white blood cells. Also, kidney function tests, BUN and creatinine. And, of course, a chest x-ray.
To see what's happening in the lungs.
Exactly. That's the minimum evaluation. Depending on how sick the person is, their symptoms, and those comorbidities, more tests might be needed.
Beyond the tests, what about the physical exam? What clues does the body give?
Oh, definitely. The physical exam is crucial. One of the most sensitive and specific findings, especially in kids and the elderly, is dyspnea.
Fast breathing.
Right, an elevated respiratory rate. That's a big red flag. Then there are the sounds in the lungs.
Like crackles.
Yes, crackles, sometimes called rails. It's this sort of crackling or rattling sound you hear when the person breathes in. It happens when small airways that were closed because of fluid suddenly pop open.
Does coughing help?
Sometimes it might improve the sound slightly, but it doesn't usually make it go away completely.
Okay. And what about consolidation? I hear that term sometimes.
Consolidation usually points towards bacterial pneumonia. It means a section of the lung has become dense, sort of solidified, because it's filled with inflammatory stuff, fluid, infection.
And how does a doctor detect that?
Several ways. When they tap on the chest over that area, percussion, it sounds dull instead of resonant or hollow.
Okay.
Also, when the person speaks, the doctor might feel stronger vibrations through their hands on the chest wall that's increased tactile fremitus.
Because the tissue is denser?
Exactly. And listening with a stethoscope, the breath sounds might be harsher, almost like listening over the windpipe, called bronchial sounds. And you often hear those crackles right at the end of the breath in, which don't clear with a cough.
Wow, lots of subtle clues. Anything else?
One more thing is a pleuritic friction rub. The patient usually reports a very sharp localized pain.
Ouch.
Yeah, and it gets worse with a deep breath or moving or coughing. It's caused by inflammation of the pleura, the lining around the lungs. We call that pleurisy.
Okay, so putting all that together, diagnosis happens. Then what about treatment? How long do people usually need antibiotics for CAP?
Good question. The recommendation is a minimum of 5 days. But, and this is important, the patient really needs to be showing clear signs of improvement, getting more stable, fever gone for at least 48 to 72 hours before stopping the antibiotics.
So not just finishing the 5 days if you still feel awful.
Correct. You need that clinical improvement. On average, treatment usually lasts about 5 to 7 days.
And the choice of antibiotic, does that depend on those comorbidities we talked about?
It absolutely does.
Mm-hmm.
For someone without significant comorbidities, relatively healthy,
Yeah.
the typical outpatient options include oral doxycycline or certain macrolides like azithromycin, clarithromycin, or erythromycin.
Okay.
There's a mnemonic sometimes used, A, B, C, D, E, azithromycin, amoxicillin, Biaxin, clarithromycin, doxycycline, erythromycin. But there's a crucial note about those macrolides.
What's that?
Doctors need to check local resistance rates. If more than about 20% of the common bacteria, especially S. pneumonia, are resistant to macrolides in that area, they shouldn't be used alone. Oral amoxicillin might be an alternative then.
Local resistance patterns matter. Good to know. So what if the patient does have those significant comorbidities? Heart disease, diabetes, etc.
Then the treatment strategy needs to be, well, a bit broader, more robust.
How so?
One option is a class of antibiotics called respiratory fluoroquinolones, moxifloxacin or levofloxacin, taken orally.
Okay.
The alternative is usually combination therapy. So either doxycycline or one of the preferred macrolides, azithromycin or clarithromycin, plus a beta-lactam antibiotic. So like amoxicillin clavulinate or certain cephalosporins like cefidoxim or cefuroxim. There's another mnemonic for this. PO-levo or moxi, meaning oral levofloxacin or moxifloxacin, with an alternative of PO-doxy with amox-clav, oral doxycycline with amoxicillin clavulinate.
Okay, so definitely a step up in coverage.
Yes, but it's really important to mention the FDA warning about fluoroquinolones.
Right, you mentioned that earlier briefly.
Yes, both the oral and injectable forms carry warnings about potential serious side effects, tendon issues, nerve problems, mental health effects. It's something doctors weigh carefully.
Okay, that's crucial context. Now, a huge question with pneumonia is always, can this person be treated at home or do they need the hospital?
That is a critical decision.
Yeah.
And there's a tool that helps doctors make that assessment quickly. It's called the CURB-65 score.
CURB-65, what does that stand for?
Each letter stands for a clinical factor,
Yeah.
and each one present gets 1 point.
Okay.
C is for confusion, specifically new onset confusion.
Yeah.
U is for urea nitrogen, or BUN, a kidney test marker if it's over 19 milli-DL.
Got it.
R is for respiratory rate 30 breaths per minute or faster. B is for blood pressure, specifically low blood pressure, less than 90 systolic or less than 60 diastolic.
Okay, CURB, what's the 65?
And 65 is simply age 65 years or older.
So you add up the points based on those factors.
Exactly. And the score helps guide the decision on location of care.
How is it interpreted?
A score of 0 or 1 generally means the person has low mortality risk and can usually be treated safely as an outpatient at home.
Okay.
A score of 2 suggests intermediate risk. Doctors might consider a short hospital stay or very close monitoring as an outpatient. It's kind of a judgment call zone.
Right. And higher scores.
Scores of 3 to 5 indicate high risk. These patients almost always require hospitalization, possibly even in the ICU, and usually need intravenous antibiotics initially.
So CRB 65 is a really practical way to stratify risks quickly.
Very much so. Helps ensure patients get the right level of care promptly.
Okay, let's shift gears slightly. What about acute bronchitis? How is that different from pneumonia?
Acute bronchitis. It's also inflammation in the lower airways, the bronchi. It typically presents with a cough, which might produce sputum, might not.
Okay, cough is central.
Yes, but the key differentiators for pneumonia are usually the absence of significant fever and the absence of tachypnea, that rapid breathing.
No high fever, no fast breathing.
Generally, no. And the cough usually lasts more than 5 days, often kicking off after you've had a cold or some other upper respiratory infection.
And it's only diagnosed if other things are ruled out.
Exactly. It's sort of a diagnosis of exclusion in people who don't have underlying chronic airway diseases like asthma or COPD.
What causes acute bronchitis typically?
Here's the main takeaway. The vast majority, probably over 75%, maybe even higher, are caused by respiratory viruses.
Viruses again,
So most cases will resolve on their own, usually within about 2 weeks. Sometimes the cough lingers a bit longer, but they don't typically need specific treatment beyond symptom relief.
which means antibiotics.
Exactly. Antimicrobial therapy is rarely indicated for acute bronchitis
Because it's usually viral.
Now, if a doctor strongly suspects one of those atypical bacteria we talked about earlier, like M. pneumonia or C. pneumonia,
The walking pneumonia ones.
right, then they might consider an oral macrolide antibiotic like azithromycin or maybe doxycycline. But that's the exception, not the rule.
So the main focus is just feeling better, managing symptoms.
Pretty much. If the cough is really protracted and problematic, interfering with sleep or daily life,
Yeah.
options for symptomatic relief might include inhaled bronchodilators. These are often delivered via a metered dose inhaler, an MDI. Things like ipratropium bromide, which is a SAMA, or albuterol, a SABA.
Similar to asthma rescue inhalers.
Yes, they can sometimes help relax the airways. Another option for significant inflammation causing that persistent cough might be a short course of oral corticosteroids, like prednisone, maybe 40 milligrams a day for just 3 to 5 days.
Okay, short bursts of steroids, potentially.
Potentially, yes.
Let's move on to asthma now. A really common condition, but maybe misunderstood sometimes.
I think so. Asthma is what we call a heterogeneous disease, meaning it can look different in different people. But the core issue is usually chronic airway inflammation.
Inflammation is key.
It is. That underlying inflammation makes the airways hyperresponsive, twitchy. They react easily to triggers, leading to bronchospasm, the tightening of the muscles around the airways.
Which causes the symptoms.
Exactly.
Yeah.
This leads to variable airflow obstruction. Symptoms typically include wheezing, shortness of breath, a feeling of chest tightness, and a Burkitt.
And these symptoms can come and go?
Very much so. They vary over time and in intensity, often worse at night or maybe triggered by exercise, viral infections, allergens like pollen or dust mites, or irritants like smoke or strong smells.
How is asthma officially diagnosed? Is it just based on symptoms?
Symptoms are a big clue, but the preferred test for diagnosis is spirometry.
That breathing test again.
Right.
Yeah.
We measure how much air you can blow out and how fast. In asthma, we look for evidence of airflow obstruction. That is at least partially reversible after using a short-acting bronchodilator medication, like albuterol.
Reversible meaning it gets better.
Yes. Specifically, we look for an increase in the FEV1, the amount of air blown out in the first second of at least 12% and more than 200 milliliters compared to before the medication. That reversibility is a hallmark of asthma.
And peak flow meters. People use those at home.
They do. Peak flow meters are less for initial diagnosis and more for ongoing monitoring of asthma control day to day.
Makes sense. What are the main goals when treating asthma?
The International GINA guidelines lay out 2 main goals. First, achieve good control of symptoms and maintain normal activity levels. Basically, let people live their lives without asthma getting in the way too much.
Okay, symptom control.
And second, minimize future risk. That means reducing the risk of asthma-related death, serious flare-ups or exacerbations, preventing long-term decline in lung function, and also minimizing any side effects from the medications themselves.
So control now and prevent problems later.
Exactly.
What about the medications? You mentioned rescue inhalers earlier.
Right. We broadly categorize them into
Mhm.
acute reliever or rescue meds and long-term controller meds.
Okay, let's start with rescue.
For relieving symptoms when they happen, the preferred approach now, according to Gina, is often a low-dose combination inhaler containing both an inhaled corticosteroid, ICS, and a specific long-acting beta-2 agonist called formoterol.
Wait, a controller med used for rescue?
Yes, specifically ICS formoterol. This is part of what's called SMART therapy, single maintenance and reliever therapy. You use the same inhaler for both daily control and quick relief when symptoms flare up,
Why is that preferred?
because studies show it significantly reduces the risk of severe exacerbations compared to just using a traditional SABA rescue inhaler alone.
SABA being.
Short-acting beta-2 agonists, that's your classic blue rescue inhaler albuterol, levobuterol.
So what about those traditional SABAs, albuterol?
They still have a role for quick relief, but they are not recommended as the preferred reliever strategy anymore if you're using an ICS controller. And here's a critical point. SABAs should absolutely not be used as the only asthma treatment, what we call monotherapy,
Why not?
because relying solely on SABAs is linked to poor outcomes, increased risk of severe attacks, and even asthma-related death. They relieve symptoms temporarily, but don't address the underlying inflammation. Over-reliance is dangerous.
Wow, okay. That's a huge shift in thinking for many people.
It really is. The focus now is much more on addressing that inflammation, even during symptom relief.
So what about the controller medications, the ones taken daily?
The cornerstone for most people is an inhaled corticosteroid, or ICS. These reduce the airway inflammation. Examples are things like fluticasone, Flaventi, butanide, Pulmicort, mometasone.
Asthmaticos.
Okay.
The ICS targets inflammation.
Right, and often they're combined with a long-acting beta-2 agonist, a LABA, in one inhaler, like Symbicort, Advair, Dulray.
ICS-LABA combos.
Yes. The ICS handles the inflammation, and the ABI provides long-lasting bronchodilation, keeping the airways open. For many patients needing more than just an ICS, these combo inhalers are preferred, especially if using the SMART approach we discussed.
Are there other types of controllers?
Yes, if asthma isn't well controlled on an ICS LABA, another option is to add a long-acting muscarinic antagonist, or LAMA, like tiotropium bromide, Spirve. This provides additional bronchodilation through a different mechanism and can help reduce exacerbations. Needs consistent daily use.
Okay. And steroids, like prednisone pills.
Systemic corticosteroids prednisone, methylprednisolone, are used for short periods to treat moderate to severe asthma exacerbations. They aggressively tackle inflammation.
How long typically?
Usually a dose like 40 to 60 milligrams of prednisone per day, orally, for about 3 to 10 days, averaging 5 to 7 days. For these short bursts, you usually don't need to taper the dose down. And interestingly, studies show taking the pills is just as effective as getting an injection.
Good to know. Any other controllers? I think I've heard of Singulair.
Ah, yes. Leukotriene modifiers, or LTMs. Montelukast, Singulair, is the most common one. They also work on inflammation, but through a different pathway involving leukotrienes.
Okay, but I feel a but coming.
There's a significant but. The FDA has issued a boxed warning, their strongest warning, about serious neuropsychiatric events linked to Montelukast.
Neuropsychiatric, like mood changes.
Exactly. Things like anxiousness, depression, sleep disturbances, problems concentrating, even hallucinations, and suicidal thoughts or behavior.
Wow, that's incredibly serious.
It is. It doesn't happen to everyone, but patients and prescribers need to be acutely aware of this potential risk and weigh it carefully.
Yeah.
If any of those symptoms appear, they need to talk to their doctor immediately.
Absolutely critical information. Okay, so with all these options, how do doctors know if the asthma is actually under control?
They assess it regularly at pretty much every visit using the GNA guideline questions. It's a quick check.
What are the questions?
Basically, in the past 4 weeks, has the patient had daytime asthma symptoms more than twice a week? Any night waking due to asthma? Needed their reliever inhaler for symptoms more than twice a week? And any activity limitation due to asthma?
4 simple questions.
4 simple questions. 0 yes answers means well controlled. 1 or 2 yes answers means partly controlled. And 3 or 4 yes answers means uncontrolled.
That seems straightforward.
It helps guide treatment adjustments. But we also look at risk factors for poor outcomes, even if the symptom score looks okay.
What kind of risk factors?
Things like using that reliever inhaler too often, even if it's less than twice a week. Frequent use is a flag. not using the ICS controller properly or enough, poor inhaler technique, that's a big one.
Makes sense.
Also having other conditions like obesity, chronic sinus problems, GERD or acid reflux, smoking, obviously, ongoing exposure to allergens or air pollution, and having poor baseline lung function like an FEV1 below 60% of predicted.
So it's not just about symptoms right now, but also future risk. And what about the physical exam during an asthma flare-up? What might a doctor find?
During an exacerbation, air gets trapped in the lungs. So on percussion, the chest might sound hyperresonant, sort of boomy.
Opposite of consolidation in pneumonia.
Right, and tactile fremitus, those vibrations, would be decreased because the lungs are overinflated. The classic finding, of course, is wheezing, that high-pitched whistling sound, usually loudest when breathing out, but can be on breathing in, too, during severe attacks.
Okay.
You might also see signs of chronic air trapping over time, like low-set diaphragms on an X-ray, or an increased front-to-back diameter of the chest, sometimes called a barrel chest.
Okay, let's shift now to COPD, Chronic Obstructive Pulmonary Disease. How is this defined?
COPD is another complex lung condition. It's characterized by persistent respiratory symptoms like cough, sputum, shortness of breath that are due to abnormalities in the airways and/or the alveoli, the tiny air sacs.
Okay.
These abnormalities cause persistent and usually progressive airflow obstruction. It's generally not fully reversible like asthma often is.
Progressive and persistent are key words there. What causes it? What are the risk factors?
We can think of it using a sort of framework. Genes interacting with the environment over time. Getomics.
Genes, environment, time. Okay.
The biggest environmental exposure by far is long-term tobacco smoking. But exposure to other toxic particles and gases from occupational settings, biomass fuel smoke, air pollution, also contribute significantly.
And the genes part.
There are genetic factors. The most well-known is alpha-1 antitrypsin deficiency, caused by mutations in the SERPINA1 gene. This can lead to early-onset COPD, even in non-smokers.
So, mostly smoking, but other factors too. What are the typical symptoms people experience?
Chronic cough is very common, often productive of sputum, especially in the mornings. Activity intolerance, or getting short of breath with exertion, is another hallmark. And importantly, these symptoms tend to get progressively worse over years.
And the goals of treatment for COPD?
They're focused on improving quality of life. So, relieving symptoms, reducing the frequency and severity of exacerbations or flare-ups, improving exercise tolerance, and improving overall health status. It's about managing a chronic condition.
How is COPD diagnosed? Is it spirometry again?
Yes, spirometry is required for diagnosis. Specifically, we look at the ratio of FEV1 to FVC. That's a forced vital capacity, the total amount of air blown out. If that ratio, FEV1 FVC, is less than 0.70 after using a bronchodilator, it confirms persistent airflow limitation, consistent with COPD.
Okay, that post-bronchodilator value is key to differentiate from asthma sometimes.
It helps, yes. While some reversibility can occur in COPD, it's usually less dramatic than in asthma. Then the severity of the airflow limitation itself, based just on the FEV1 value, is classified into Goldie stages 1 through 4.
Got it. What about medications for COPD? Are they similar to asthma?
There's overlap, but the emphasis can be different. For quick relief of symptoms, short-acting bronchodilators are used as needed, both SABAs like albuterol and SAMAs like ipratropium bromide.
Okay, rescue meds.
For daily maintenance, long-acting bronchodilators are really the cornerstone. LAMAs, like tiotropium, and LABAs, like salmeterol or formoterol. These help keep airways open longer and are crucial for reducing exacerbation risk. Often patients use both a LAMA and a LABA.
So, long-acting bronchodilators are central. What about inhaled corticosteroids, ICS?
ICS can play a role in COPD, particularly for patients who have frequent exacerbations or features that overlap with asthma. They help reduce inflammation and minimize exacerbation risk.
Oh.
But unlike in asthma, where they are fundamental, their role in COPD is more targeted. And it's important to know they come with a modest but documented increase in the risk of developing pneumonia in COPD patients.
Ah, okay. So a trade-off to consider there. What about COPD exacerbations? What triggers those?
An exacerbation is defined as an event where the person's usual dyspnea, cough, and/or sputum production worsen acutely, typically over less than 14 days, and often requires a change in regular medication.
What causes them?
The main triggers are respiratory infections viral, like RSV, influenza, COVID-19, or bacterial. Environmental factors like air pollution or other irritants can also set them off. While specific bacteria like Haemophilus influenza, Moraxilla catarrhalis, or Streptococcus pneumonia can be involved, often it's more about overall inflammation triggered by an infection or insult.
How are these exacerbations treated?
Treatment focuses on intensifying bronchodilator therapy, using the short-acting ones more frequently, maybe adding long-acting ones or ICS if not already on them.
Okay, more bronchodilators.
Systemic corticosteroids, like oral prednisone, are often used for about 5 days. They've been shown to shorten recovery time, improve lung function quicker, and reduce the risk of relapse or treatment failure.
Prednisone again. What about antibiotics?
Antibiotics are a bit controversial in the outpatient setting for COPD exacerbations. The evidence is mixed. They are generally not indicated for mild to moderate exacerbations unless there are clear signs of bacterial infection, like increased sputum purulence plus increased sputum volume or dyspnea.
So not automatic like in pneumonia.
Definitely not. If they are prescribed, usually for more severe cases or those with clear bacterial signs, it's typically an oral agent for 5 days. Lots of options depending on local resistance and patient factors, amoxicillin, doxycycline, macrolides, fluoroquinolones, etc.
Okay. And sometimes people with COPD need long-term oxygen, right?
Yes, for severe COPD with chronic hypoxemia, low oxygen levels in the blood.
What are the specific criteria for starting it?
Generally, it's indicated if the arterial oxygen pressure, PaO2, is consistently 55 millimeter Hg or less, or if the oxygen saturation, SaO2, is 88% or less, measured at rest while breathing room air.
Okay, specific numbers there.
Yes. Or if the PO2 is slightly higher, between 55 and 60 millimeter Hg, or SeO2 is 88%. But there's also evidence of complications like pulmonary hypertension, peripheral edema suggesting heart failure, or polycythemia, which is an elevated red blood cell count.
And how much do they need to use it?
To get the survival benefit, it needs to be used for more than 15 hours per day, enough to keep the SO2 at or above 90%.
Wow, that's a major commitment.
It is, but it can significantly improve survival and quality of life in the right patients.
Beyond oxygen and meds, what else is crucial for managing COPD?
Proactive care is huge. Smoking cessation is absolutely paramount, the most effective thing someone can do to slow disease progression.
Number one, always.
Always. Then staying physically active is important. Pulmonary rehabilitation programs can make a massive difference in exercise tolerance and symptom management. And keeping up to date on vaccines, influenza, pneumococcal, RSV, and COVID-19 is critical to prevent exacerbations.
Those preventative steps sound key.
They really are fundamental to long-term management.
Okay, let's broaden out a bit. We've talked about cough as a symptom in several conditions. What about just managing a persistent cough itself, maybe after an illness?
Right, that lingering cough can be really annoying.
Yeah.
For an acute cough, like with a common cold, some older first-generation antihistamine decongestant combos might offer slight relief, but honestly, the evidence is pretty weak.
So maybe helps a little, maybe not.
Pretty much. And it's worth noting, the newer non-sedating antihistamines like loratadine or cetirizine, they don't really do anything for cough.
To know. What about for kids?
For kids over 1 year old, a teaspoon of honey given at bedtime seems to provide some relief for a nighttime cough. Simple, but some evidence behind it.
Honey, interesting. Now, what about that cough that sticks around for weeks after you've gotten over the cold itself? The post-infectious cough.
Ah, yes, the cough present for maybe 3 to 8 weeks after the initial infection symptoms are gone. It can be really frustrating.
So frustrating. What helps?
Again, the evidence is not super strong for anything. Some sources suggest that inhaled ipratropium bromide, the SAMA, or even an inhaled corticosteroid may help attenuate it, make it less severe or shorter.
May help?
May help. If you try an inhaled corticosteroid, it usually takes about a week to notice a significant effect, so it requires some patience.
Okay, what about for really severe, debilitating post-infectious cough?
In those cases, after ruling out other common causes of chronic cough, like underlying asthma, sinus issues, GERD, some clinicians might consider a very short course of oral prednisone, maybe 30 to 40 milligrams a day, for just a few days.
But only after ruling other things out.
Absolutely. And here's a really important caveat from research. Studies have actually found oral prednisone to be ineffective for treating cough in adults who don't have asthma. So it's definitely not a go-to solution.
Okay, so use with caution and probably limited benefit for most.
Exactly. Finally, we should touch on central-acting cough suppressants, things that work on the brain's cough center.
Like codeine.
Like codeine,
Yeah.
and also dextromethorphan, which is in many over-the-counter products.
Yeah.
These need to be used with extreme caution.
Why is that?
Well, codeine is actually contraindicated, meaning it shouldn't be used at all in children under 12. And dextromethorphan is contraindicated in children under 2.
Okay, serious age restrictions.
Yes. And both should be used with extreme caution in people who are breastfeeding due to potential effects on the infant. The overall message is, Suppressing a cough isn't always necessary or even desirable, and these agents carry risks, especially in vulnerable populations.
Good points. Safety first.
Always.
Wow. Okay. We have covered a lot of ground here. We've dived into pneumonia, bronchitis, the complexities of asthma and COPD, and even tackled that common enemy, the persistent cough.
We really have. And hopefully understanding some of these nuances, the subtle differences in symptoms, why certain tests are done, how treatments differ, isn't just, academic information.
Right. It feels practical.
Exactly. The goal is to empower you, the listener, to be a more informed participant in your own health conversations, knowing what to look for, what questions to ask your doctor. It makes a difference.
It really does. So maybe a final thought to leave people with. What does all this mean for you listening? The next time you or maybe someone you care about faces a respiratory issue, a cough, shortness of breath, how might knowing this stuff change things?
Yeah, how might it shape the questions you ask, the observations you make about symptoms? Maybe even influence your decisions alongside your healthcare provider.
That power of being truly well-informed.
Yeah.
It really is, well, a breath of fresh air, isn't it?
Couldn't agree more.